So now I have the pleasure of introducing our next speaker, who also needs no introduction, and this is Dr. Norm Silverman. Dr. Silverman is Professor of Pediatrics at the University of California, San Francisco. He's also Professor Emeritus at Stanford University. Dr. Silverman will share his perspective on cardiac imaging.
Thank you, Mel. It's a great honor to be here, and thank you very much for having me as a representative. When I was asked to give this presentation, I was asked either to honor an individual or some aspect of imaging that would be a flagstone of what has happened over the past 50 years in ultrasound imaging. And so I have chosen to combine both of those and talk about my good friend, Dr. Roberta Williams, who described the subxiphoid, as I call it, subcostal view. Roberta started her life as a technologist working for Dr. Ernest Craig of North Carolina. And here you can see her in the animal lab, where she is a strand of straw in her mouth and is busy monitoring an instrumented calf. So she has a large background in medicine, in physiology, and she eventually went on to describe this subcostal or subxiphoid view. And this I've taken from her original picture because I think it's important that we appreciate how ultrasound has advanced over the course that we have seen it in the last 50 years. Many of these early pictures needed labels because you were unable to recognize anything, and sometimes even diagrams. Now, Roberta did a remarkable thing. She decided to speak to one of the engineers about flipping the image into anatomic orientation. Because we all read upright. If I put that title on upside down, it would have taken you much longer to recognize it. And of course, one has to scan a whole image to make this view. So Roberta did a number of things that were interesting and also serendipitous, because the probes that we used were what they call a mechanical or toothbrush wobbler. And this wobbler was very difficult to use. So here is what essentially we were looking at, and of course that had to be placed in as well so that people could really understand that they were looking at a cardiac image. Now, Roberta went on to be the chief of the sensitive care, which I call, is my name for intensive care. I used to call it expensive scare, which is also useful. And then she became the chief of cardiology at UCLA. She became the chief of pediatrics in North Carolina at the University of North Carolina, and has twice been the chairman of pediatrics in University of Southern California, or as I prefer to call it, the University of Spoiled Children. Now, the people that she's trained is really the whole spectrum of people in here. There's first of all Fred Behrman, who worked with her initially. The great Dr. Stephen Sanders, who has again also gone on to be a director of a division. Dr. Stephen Colin, Dr. Ira Parnes, Michael LaCourte, and Steve Lipschutz. And also I left off somebody important, Pierre Wong, trained there, and Dr. Jerry Marks. Jerry, can you just stand up so people can see you were trained by Roberta? Okay. Jerry used to be 6'5". And Tal Gaver, who is now the current chief at Harvard. In yellow, I've put her trainees from the UCLA group, Tom Klitzner, who is the chairman, Wyman Lai, who is now heading the unit in Southern California, Stacy Drant, and many, many others. So these were the first pictures that she took, and this shows something that we think of is inconsequential now, but a hole in the atrial septum between the right and left atriums. And this was then inverted to the position that we now use, that Roberta did. Now, I've used this subcostal view as an evolution that occurs within our cardiac timing. And what I have in here is something that we all know and love. This is a picture of a tetralogy of Fallot. And the morphology is somewhat better than it has been in the past. And the developments that have added to our understanding and thrill have been the presence of the use of Doppler color flow imaging, which can be superimposed upon the image. There's one frame with color and one frame without color, and you can see the narrowing within the right ventricular outflow tract. I'll take the labels off so that you can see that. And also there's a yellow signal within the pulmonary artery representing a patent ductus arteriosus. We can then use orthogonal planar imaging to show what we see on a lateral variation of the images. We used to call these lateral equivalents, like a chest X-ray, and essentially we're looking at those things. You can see where the head is, and you can see where the front of the heart is. And we see the pulmonary trunk, the pulmonary valve, the right ventricular outflow tract, and that classical feature of tetralogy, the anteriorly and superior deviated outlet septum. I'll take the labels off, as well as the patent ductus, which is seen coming off the arch of the aorta and entering the bulb of the main pulmonary trunk. Dr. Eugene Braunwald in 1990 said that transesophageal echo can be regarded as one of the most important innovations since the heart-lung machine. I didn't say it, Braunwald said it. And if Braunwald said it, it must be correct. Anyway, I think that this is a transesophageal echo, and what we learned from Roberta and her colleagues was that if we took this probe, which we passed through the esophagus into the stomach and flexed the probe in a forward direction, it was like looking at a subxiphoid view image. So here is a tetralogy looking at it from the perspective through the stomach. And it looks just like the last image that I showed you in the frontal plane. The nagging flashes that you see coming around are due to the miserable surgeon's diathermy, which always interferes with your image. So there you see identically the same thing, the overriding aorta, the narrow outflow tract, and the smallish pulmonary artery. Now lastly, I have on here the use of what has become a therapeutic technique, so that not only has ultrasound been involved in monitoring etc. issues, but can be used as a guide, and in many places in the world, that especially the ones I have worked at, this is done on a routine basis. The wonderful thing about subxiphoid imaging is that when you put your hand with the probe on there, you can feel whether the Rashkin is successful or not. So here's an example of a jerk of a Rashkin catheter across the atrial septum, indicating as well the use of this technique as a monitoring and therapeutic issue. And as they say in Rashkin parlance, one good jerk deserves another. And so this was done by me in Malaysia. Interestingly, there's nobody around anymore. When this was first done, the room was full of people that gawked at the assistant monitor so that they could see this. Today it's become so routine that nothing happens. Well, as I said, one good jerk deserves another. And here is this jerk. And after a second time, you can see the balloon ruptures. Well, I mean, that's not a good thing, but what it does show you is that the addition of aerated saline, or even this with a little dye in it, can be passage across the atrial septum, and you can see that there is not only a left to right shunt, but now also a right to left shunt, indicating a successful Rashkin. So I think ultrasound has evolved over the years. I've sort of stopped at this point, but ultrasound hasn't continued to be on its laurels. There are many techniques that have become available, such as tissue Doppler, strain rate imaging, and three-dimensional echocardiography, all of which have become very important modalities that are used from this fascinating technique, which is online, portable, and gives you immediate answers. Thank you very much.